This is a lower quarter screening examination. The purpose of this video is to demonstrate a lower quarter screening examination which we expect you to be proficient in and repeat throughout this internship. Dr. Bennett has provided an introductory video which describes the purpose and value in a regimented physical exam process. This screening examination progresses in a positional fashion from standing to sitting to supine and prone. The screening examination is intended to clear regions of the body as origins or contributing factors. Keep in mind that some items may not be indicated during all examinations, such as neuromuscular screening exam on a patient without neurological symptoms, but that you should take an opportunity to practice the full screen anyway, especially during the next few weeks until you have it down. Also, it does not include many of the special tests for certain regions of the body. These will be discussed separately in later modules throughout the Clinical Excellence Network. You will start with a functional screening examination. Often this starts with observing your patient's gait as they walk back to the treatment area. You'll have them walk on their heels and their toes to assess lower root function, while squatting assesses upper and mid-lumbar roots. Single leg stance can demonstrate hip weakness or balance dysfunction. Notice that the patient has been asked to remove his shirt so that postures and movement impairments may be observed during screening. During active range of motion of the lumbar spine, you will use a standardized position, and you may provide overpressure based on the severity and irritability of your patient. When performing overpressure and flexion, ask the patient to flex their neck as well, as this will allow you to assess some of the neural dynamics. Quadrant testing will fully load lumbar facets as the patient is overpressed in this position. Quadrant testing may be deferred if a patient is highly irritable or has lower extremity symptoms that are increased in extension or ipsilateral side bending without combining motions. In sitting, neuromuscular screening exam may be performed if there is an indication that the patient has neurological symptoms or a likely radiculopathy. But again, for the next couple months, practice this procedure with each of your patients during lower quarter screen until you have it committed to memory. If indicated, perform a seated thoracic examination with active range of motion and overpressure into flexion, extension, and rotation for the thoracic and rib cage regions. Also include inspiration and expiration. Then perform a slump test for the lower extremity neurodynamics in sitting, starting with trunk and neck flexion, and then adding in knee extension and ankle dorsiflexion. This test should be overpressed and sensitized until symptoms are either reproduced or sufficient tension has been developed in the musculoskeletal system. Much of the screening exam will occur in supine. It begins with active straight leg raise with passive overpressure to assess neurodynamics. Similar to slump, this should be overpressed until significant myofascial tension is developed in the absence of neural symptoms or if neural symptoms are reproduced. Then hamstring flexibility can be assessed with popliteal angle at 90 degrees of hip flexion. This may be measured with an inclinometer if restricted flexibility exists. Then the patient should really flex the hip actively prior to applying passive overpressure, and then the hip is scoured. Maintain close contact with the patient during these maneuvers. Also keep in mind that if the patient's primary complaint is knee pain, you may have to modify your position and handhold to avoid aggravating the knee. This applies to providing overpressure into internal and external rotation of the hip as well. The patient is then returned to 90-90 and the hip is tested in internal rotation and brought into the impingement position or fader position. Note that for the purpose of demonstration, I've separated these two movements out by returning to neutral in between them, and I've maintained some separation to view the position of the leg during this test. However, proper technique is performed with similar contact to hip flexion and scour testing. Then returning to 90-90 for external rotation, followed by a Faber test. Make sure to apply a stabilizing force to the opposite ASIS to minimize lumbopelvic movement during this test. Also note that hip rotation can be performed in prone, which allows for easier goniometric measurement as needed. Then the patient is asked to actively flex the knee where overpressure is applied into flexion quadrants by applying internal and external rotation force through the tibia with the hand distal at the heel. Then the patient actively extends their knee, followed by overpressure into extension into similar quadrants. Then in a relaxed position, patellar mobility is assessed in 4 directions, along with patellar rotation, maintaining broad contact with the patellar borders. Then proximal tib-fib mobility is assessed at about 60 to 90 degrees of knee flexion. Force is applied in a posteromedial and anterolateral plane of motion. The knee is again extended and distal tib-fib mobility is assessed. Keep the elbows straight and apply force with shoulder girdle movements. The patient is then asked to actively dorsiflex and plantar flex the ankle. Overpressure is applied. The same approach is taken with inversion and eversion. Then accessory glides are applied to the rear foot with AP, PA, medial, and lateral glides. Midfoot mobility is assessed through the tarsals and metatarsals. Active toe flexion and extension is followed by passive overpressure and dorsal volar glides as well in a similar fashion. The patient is then placed in prone where lumbar spring testing is performed with central and unilateral PAs. Maintain elbow extension and apply a consistent force, noting the beginning of resistance, terminal resistance and end feel, and tissue quality. Also monitor the patient for pain reproduction. The patient is then asked to actively extend the hip and overpressure is applied. Quad flexibility is assessed with prone knee bending. Then the patient is brought into hip extension with the knee at 90 degrees for hip flexor flexibility And finally, overpressing into the knee flexion in this position for femoral nerve tension testing. Again, the prone position may alternatively be used for hip rotation mobility testing as demonstrated here. Keep in mind that your clinical faculty will guide you further with these techniques and that variations to the screen exist. Also remember that components of this examination executed in a different order and to a different extent based on findings from the patient interview might be appropriate at times. So that's the complete lower quarter screen. We will be monitoring your success throughout the internship.